It's been 8 years since the passage of the Affordable Care Act, also known as Obamacare. Republicans failed to repeal it, but have curbed it some. California's all in with the ACA, providing coverage to more than 7 million people. Is that good enough? And what about cost and quality of care? Why do Walmart, Amazon, and other corporate giants want to get into the healthcare business? And can we ever get a handle on the opioid problem? Barry Arbuckle is someone to ask. He runs one of the region's largest hospital groups, and he's been involved in healthcare policy on both the state and national level. Barry Arbuckle, he's next on Inside OC. Inside OC is brought to you by...
Each new community 5 Point brings to life represents a promise delivered. Great neighborhoods are more than just places to live, they are places to connect. 5 Point is a proud sponsor of public television and community programming.
Chapman University is a proud sponsor of Inside OC and community programming.
They have a good history.
Huh.
Yeah.
Hi, I'm Rick Reiff, and I'm talking with Barry Arbuckle. Barry, thanks for coming on.
Thank you.
And full disclosure, Memorial Care Health System is a long and loyal sponsor of Inside OC, and that's the only reason you're on, by the way. No,
I don't blame you.
No, clearly you are a leader in healthcare, both locally, state, and nationally. And that's why you're on to talk about what's going on with healthcare. Just briefly, tell us, what is Memorial Care Health System?
Well, Memorial Care is a nonprofit integrated healthcare delivery system. In addition to our 4 adult hospitals, we also have 1 dedicated children's hospital. We span South Los Angeles County through Orange County.
And what are the hospitals?
Hospitals are Long Beach Memorial, Middle Children's Hospital, Orange Coast Memorial, Saddleback Memorial, and Community Hospital of Long Beach.
Okay. You also have a lot of doctors. You got outpatient clinics and that kind of thing?
That's one thing that makes Memorial Care unique compared to most other health systems in this region and elsewhere, in that we have 5 hospitals. We have over 200 locations. Some are primary care physician practices, some are specialty practices, and then we have a series of urgent care centers, surgery centers, imaging centers, dialysis centers spread throughout the region.
Okay. What's the work that you've done both on the state level and the national level in healthcare?
I've been involved in healthcare legislative activity for a number of years. Through some of the traditional sources like the California Hospital Association, which is sector specific, or the California Association of Physician Groups,
right.
and then at the national level with the American Hospital Association. But in the last 7 or 8 years, I've become much more involved in associations that look at healthcare from a more integrated perspective. The Integrated Healthcare Association is based in Oakland, California, and has hospitals, physician groups, the government, both state and federal, pharmaceutical companies, health plans, that all look at healthcare together and try to look at how we can improve it in California. And then I'm on a national group called the Healthcare Leadership Council that does the same thing at the national level. Okay. And then one other organization that I've just become a part of in the last year is the Bipartisan Policy Center, based in Washington, D.C. I'm in the healthcare division of that. And it's truly bipartisan. It was started by Bill Frist, a Republican, and Tom Daschle, and then it's supported a Democrat, and then supported by Gail Walensky, who worked under I think W. Bush, as well as Andy Slavitt, who headed the CMS under Obama. And we again look at things from a very holistic perspective and try to move healthcare in the United States forward.
So you go to Washington from time to time to talk about these things, and do the politicians listen to you?
You know, for the most part, I think they do, because they don't really understand healthcare. I mean, some do. Some are physicians and come from the industry, but they have to deal with so many different things, defense and water and just endless numbers of things. And so they're looking for folks from healthcare to explain to them what needs to change. And my emphasis on my most recent involvement in these more holistic organizations that look at healthcare not just from a health plan perspective or a physician perspective, but from the entire perspective. They know when we make a recommendation, it's not trying to advance one sector in healthcare, and that's why they tend to listen to us.
So then my question is, why do we have such a screwed up system. Okay, why? You know, how it seems like America is unique in the complication of our healthcare system. Why is that?
Well, it is unique, and it is. I think it was Peter Drucker who said, he was talking about hospitals, not the entire healthcare system, but he said hospitals are the most complicated human organization on earth, and they are. Probably several reasons. One, we have a system that is. Actually, it's a hybrid of systems from throughout the entire country. By example, if you're under 65 and working, we're a lot like Japan or Germany, where your employer probably buys your health insurance, you contribute to a copay, and then you go into the private system. If you're over 65, we're a lot like Canada, where the government owns the healthcare system, and the physicians and hospitals are private, and you can go to them as well. If you're a Native American or you're a veteran, you go to a different system, which is the insurance company is owned by the government, the doctors are owned by the government, the hospitals are owned by the government, and you pay next to nothing, there are no bills. So you really have three different systems, and if you're uninsured, it's a lot like rural India, where there's really no system unless it's an emergency. And regardless of insurance status in the United States, if you have an emergency, you are cared for and cared for very well. But you don't have the benefits of having some of the preventive care. So we have this kind of hybrid system. We have both, you know, public and private aspects of it, which I think is a good element of the U.S. healthcare system, because they keep each other honest, in my opinion. I think it's a good balance if we can continue with that. That's why I'm not a big fan of the so-called single-payer type system. I don't think those are as effective.
Well, but doesn't almost every other country have single-payer?
You know, it's interesting. They have different versions of it because there's no uniform definition. They have, probably the better way to refer to it is they have universal coverage, which is something I believe the United States needs to move to. In fact, by example, I think there are roughly 200 nations in the world. 40 of them have some form of an organized health system. 39 of them endeavor to insure all citizens or make sure they are covered with insurance coverage. One does not.
Gee, I wonder which one that is.
Until the Affordable Care Act. I mean, give Obama credit, that was part of the impetus.
But even that didn't get everybody.
It didn't, but it got a significant number of them. And so it was a move in the right direction. Now, I wasn't a fan of the financing of it and some other elements, but it moved us in the right direction. Other countries, I've had the opportunity to study health systems in 8 or 9 different countries. I mean, on the ground with providers, administrators, in some cases the people who developed the health system, the academics. And they're all very, very different. I mean, I'll give you an example. I was in Hong Kong, which is more of a socialized medicine country. So the government pays for virtually everything, including things, as I walked by pharmacies in Hong Kong and saw things on the wall that I could not recognize. But it's paid for because it's herbs and things that may or may not be effective. And I was chatting with an employer there, a major employer, and we were just talking, and he just mentioned by happenstance their employer-sponsored health insurance program. And I said, you're in Hong Kong, everything is paid for by the government, why would you have that? And his response was interesting, I've never forgotten it. He said 3 words, jump the queue. I said, what do you mean? He said, jump the line. He said, if you're in the government system, say me, mid-50s, I'm out this weekend playing soccer and I blow out my knee. If I'm in the government system, it's 6 to 8 weeks before I get an MRI to see if I need knee surgery. So what they do in that country, if you have an employer-sponsored insurance, you jump from the public system to the private system. You have your MRI that afternoon. It shows you need knee surgery. You jump back into the public. You get your surgery immediately. And so for them, it's more of a competition, a way to.
Aren't there? I mean, isn't that Britain and even
many of the countries that we think have this pure, seamless, single payer really don't.
All right, because they have like the basic universal coverage, and then you jump the queue or you get extra coverage or something with insurance. Well, can't we reverse engineer our system to do the same thing?
That's where I think we're headed. I mean, by example, Medicare, we've heard many times that Medicare is on a glide path toward insolvency. The Medicare trustees say it will be insolvent in 10 years. And the Congressional Budget Office, which is nonpartisan and analyzes every bill in Washington, D.C., I think gives it 7 years. Now, by insolvent doesn't mean it's going to be bankrupt. It just means it won't have enough money actuarially to pay for what needs to be paid for. So that system in and of itself can't continue. That's why Medicare Advantage, which is kind of the private version of Medicare, came about, which I'm a big fan of that one. But with what we're seeing in these other countries is because they can't continue to afford all that coverage, they're adding private sector elements to it.
Okay, and so with the Affordable Care Act, we now had a new administration, Donald Trump writing orders undoing much of what, or trying to undo what was done, and scoring a couple of points here and there, I guess. What's the status of it? What is our situation now? Where are we headed in healthcare?
Well, I guess there's both good and bad. On the good side, at least with the Affordable Care Act, as we talked about a moment ago, it at least increased or decreased the number of uninsured. That's a good move in this country. Now, how much the most recent action by the current president in his tax plan, which eliminated the insurance mandate, how much that will have an impact, I don't know, but I suspect it will. And that's not a good situation. We're in kind of this funny position. I mean, on the insurance mandate, we have no more requirement to have insurance. Yet we still have a requirement that if you get sick or injured, a health plan has to take you. You can't, that defies actuarial science. You cannot have that. That's like...
What's likely to happen then? For those people paying for insurance, their rates will go up?
Without a doubt, because human nature or behavioral economics would say, if I don't have to buy insurance, but I know I'm going to be covered if I need it, I'll wait till I need it. I mean, it'd be equivalent to you, I presume you probably live in one of the fire zones in Orange County, of you deciding not to have fire insurance and saying, you know what, I feel safe. I've got planting around my house won't burn, and a fire sweeps through. And that afternoon you call State Farm and say, sign me up. And they have to do it by law. They have to replace your house, and you haven't paid one dime of policy.
Sounds good to me.
It sounds like a wonderful idea, but it's not sustainable.
Okay.
So the move toward more and more insurance was good. We'll see what this removal of the mandate does. The other movement I think that was good with the Affordable Care Act is that it started with the government, began to evolve its payment for health care from volume-based, where they just pay when people are sick or sicker, to value-based. They're paying more for quality, and they're holding providers responsible for quality outcomes. Now, it was clunky along the way because when you change systems, and particularly when a government says, well, this is how we measure quality, it may or may not be perfect. But it was a move in the right direction. It's slow, but the private sector has said, oh, that's the direction the country is going. Let's jump on that bandwagon.
Well, that's interesting.
And they've moved it along.
The insurance aspect I was aware of, more people are insured. I haven't heard many people say that the Affordable Care Act improved or has improved quality of health care. You're saying it has had an impact on
I think it has, because it's forced the providers to not just be paid, regardless of what happens to the patient when they see the patient.
What's an example of something that has changed?
There's multiple quality measures now with Medicare, where we have to submit data to Medicare, and what they do, they'll say you should be paid this amount of money. We're going to hold back, say 8 or 9%. We want you to submit data to us, and you have to meet certain quality indicators.
Well, what might the data be? Let's say if somebody, what's a procedure?
Could be immunization rates. It could be readmission rates to the hospital. Those need to be very low.
Okay.
Screening rates. There's a host of things. Infection rates. A host of things they look at. And the higher you score, the more money you get back.
Now, how about cost? Has the Affordable Care Act had an impact on the cost of health care?
That's tough to tell. I mean, you'll hear varying reports, but they're convoluted by what's happened in the economy at the same time. As the economy slows down, of course healthcare costs slow down, and people took credit that the Affordable Care Act must be doing that. I'm not sure that it did. But I think it's setting us on the trajectory where we can begin to control that.
All right. Something big in the news. Walmart wants to buy is it Humana?
Big insurance company.
A big insurance company, and Amazon says it's going to, go into healthcare. What's going on here where these giant corporations are getting it into your turf, Barry? What's going on?
Well, they're getting into healthcare. CVS buying Aetna. I think they look at health. These are by and large innovative companies, and they look at healthcare as needing kind of a systemization and a fix, and they think they're the ones to do it. And so they are disruptors. And a lot of folks look at that and say, oh no, they don't belong in healthcare, or what's going to happen to us. I think it's a good thing. I think disruption in any industry is good. And I think it spurs us, mainly in the private sector, to move things along more quickly. Now, they're going to find out what President Trump found out about healthcare when he said healthcare is, who knew healthcare was really that complicated? They're going to find that out. It's not that easy to fix. It's not like, you know, the routine of sending packages to someone, or the routines of, you know, whatever they may do as a business.
Yeah.
Another reason I think we're seeing a lot of these transactions you're seeing have as some element pharmacy. They want to get control of the pharmacy spend. They see grand opportunity for that, both in terms of controlling the cost, but also the pharmacist being a common point of access for patients. You probably see a pharmacist, most people do, more than they do a primary care physician. For any number of little medications you may pick up, and you have the opportunity to interact with that pharmacist, they see that as an opportunity to bend the cost curve in healthcare.
Interesting.
Either for their own employees, but also for folks in the community.
Well, interesting you should mention pharmacy, because one of the other big things in the news that I wanted to talk to you about is the opioid crisis.
Oh, yes.
And how does that play into the whole healthcare situation?
I'll tell you, it's concerning from several perspectives. I mean, on one hand, from kind of a macro perspective, I was reading a research report recently that was looking at kind of the classic thing we look at in healthcare, the cost of U.S. healthcare being one of the highest per capita in the world, in fact, the highest, but our life expectancies aren't as high. That's an overly simplistic analysis. It's the most common one out there because there are a lot of confounding factors. One, we're one of the more heterogeneous societies in the world, and that has an enormous impact on life expectancy, for example. There's a host of other factors. But one of the things that I also was surprised to learn, the United States has the highest homicide rate and the highest opioid death rate compared to almost any other country. Let's say you look at the European countries, by a long shot. And to what degree does that impact life expectancy? I don't know how much impact it has.
So why is that?
I mean, it's one of the societal ills we have in this country. I think it's in large part the lack of emphasis on the social services and the behavioral health services in the country. One of the most interesting charts I've ever seen, going back to that chart where you can imagine country by country showing their per capita cost for healthcare, and they're here, and the United States is up here. However, when you overlay on top of that, not only the medical cost per capita, but also the social service cost per capita, the United States is right in the middle. But we're the highest on medical and the lowest on the social services. Countries that have lower medical spend more on social services. So it might be that if we spend more on some of the social services, looking at homelessness, looking at behavioral health, looking at food availability, et cetera, we might be able to lower our medical expenditure as well.
What do you think about pharmaceutical advertising?
I'm not a big fan. In fact, I've often said that particularly as President Trump was signing executive orders seemingly once a week, I was wishful that he would sign an executive order that did not allow pharmaceutical companies to advertise on television. I think it does a great disservice, not only to the U.S. healthcare system, but also to the individual. You've seen those ads. You listen to them, and somebody that can speak much faster than I can, at the end of it goes through all these horrific possible complications that's required by law, and you kind of glaze over, but you see these images of people running on the beach, and they have an illness that sounds, maybe it's familiar to what you have. You want that medication. You don't care what it costs. And you go to your doctor and say, can I have that? And sometimes the doctors are very, very smart. They do what's best for their patients, but they also see a lot of people very quickly, and they want to keep high patient satisfaction. I think it's really just doing a grand disservice. It's interesting, there are only 2 nations in the world that allow pharmaceutical companies, drug companies I should call them, to advertise to consumers. Us and I want to say it's New Zealand. No other nation in the world permits it, and I think there's good reason for it.
Wow.
And harken back to the opioid crisis, the company that is the primary distributor in the United States of opioids has been advertising them directly to consumers for years.
Now, in most of those cases, though, if you want the drug, you have to go to your pharmacist, right, and say that.
You should have to go to your physician to get a prescription, and then the pharmacist to pick it up.
Right.
Yep.
And I was surprised because, you know, I knew you had this feeling about pharmaceutical ads, and in just talking to people that you were coming on. First of all, I was astonished. I don't think I talked to one person who didn't think it was a good idea to ban pharmaceutical ads.
Good.
I don't know if there's been, I haven't seen any polling on it, but I think that would be very popular with people. The other thing is, I said, oh, come on, doctors, they're controlling it. A doctor can say, yes, you saw the ad, but you don't need this, this isn't good for you. But I've been told, no, really the physicians are under some pressure because they don't want that person to go to another physician who will prescribe it for them.
I think there could be some of that. There's also, not to get too wonky, but in research reports on new drugs, it's not as straightforward as it needs to be, and physicians rely upon those. I mean, for example, if you heard a new drug for a condition that you had, a brand new drug, who cares what the cost is, could reduce the incidence of what you have by 40%, you would probably say, I want that drug. Now, what if that 40% though brought it from 3.5% likelihood that you would have this condition to whatever, 2.2, but it cost $25,000 a year? You might pause and say, a 3.5% chance I have this illness reduced to a 2 point something for.
Don't physicians understand that?
It's not published, and they can't possibly keep up with all that information. The number of new drugs and research reports that come out is unfathomable.
Right. Now, on the other hand, because you know we are here in Orange County, which is a bedrock of the biomedical and pharmaceutical industries, you know, are you concerned that if you come down too hard, you stifle innovation? These drug companies do come up with, you know, wonderful products that extend lives, improve lives, save lives. You know, is it going too far to say you can't make money?
I don't think so. I mean, they can make money in a lot of other countries that don't allow advertising, for example. And you're right, the biomedical and the pharmaceutical companies have wonderful innovations that can improve and extend human life. But we need, I think, a more transparent system so that folks can look at it and say, yeah, that one makes sense. That one's worth it. That one's just not a tiny incremental improvement for a significant expenditure. The system can't afford it any longer.
It's always fun to hear you talk, and we've had some conversations, and because you have so many interesting ideas. Banning pharmaceutical ads is one.
Some are more radical
Something else
than
you've
others.
talked about are the idea of outpatient procedures versus doing it in a hospital, and you think the system is not doing what it should be doing. Explain that.
Yeah, I do, and we've thought this in memorial care for a number of years. Historically, hospitals provide both inpatient services or acute services as well as outpatient services on the campus of the hospital, sometimes in the same facility or at least on the same campus. And the cost of those services, the cost to provide them, is higher than it would be if it were at a community-based center for the same procedure,
Give an
same
example
patient.
of a procedure.
An MRI, for example, of the brain, let's say. Let's make it a serious MRI. MRI of the brain, outpatient procedure. The difference in price, and I'll come back to cost. The difference in price, same patient, same procedure, many times the same radiologist reading the image, between a hospital-based imaging center and one that's based in the community that's more market priced, 300 or 400% difference.
And in terms of dollars, what are you talking the difference?
$1,200 to $6,000.
Okay.
I mean, it's sizable.
Several $1,000s
It's sizable,
difference.
and this is
Okay, so just do them all in the outpatient.
in the community-based.
Yeah, do it in the community-based.
Well, that's the way we're trying to move it. Now, let me, kind of defend why the hospital prices are higher. It's because the costs are higher. I mean, you're in an acute care setting, you've got a lot more regulation, you're in more expensive buildings, and I would argue that the cost should be higher, but I also argue that that's not the right question. The question is, does this patient need this, they need to have their procedure done in proximity to an acute care hospital, even though it's an outpatient procedure, in case something goes wrong or in case there's a complication, or can they be cared for out in a community-based setting? The kind of the layperson's example I give, and it may not be the best, I need to talk to one of my doctors and get a really good one, but it would be going back to blowing out my knee on the weekend playing soccer, and I need, say, a knee replacement procedure. I would have a knee replacement procedure in one of our ambulatory surgery centers, not licensed under the hospital, out in the community. I'm in by 6, surgery is done by 8. I walk at 1, I walk at 4, I go home in the evening. The price is a fraction of what it would be in a hospital setting. My mother, who is in her late 70s, may have a few typical complications of a senior. Knee replacement procedure probably should be done in the proximity of a hospital. So I asked our clinicians at one point several years ago, of all the patients that are seen in hospital licensed imaging centers or surgery centers, the more expensive ones, which ones clinically need to be there, if you can tell? And the answer varied a little bit by what data set we were looking at, but roughly 20 to 25 probably need the extra services of a hospital. 75% don't.
Wow. And on that point, we have run out of time, but we'll continue talking on our open mic segment coming up. Barry, thanks.
Absolutely.
Again. That's it for now. Thanks again to my guest, Barry Arbuckle. You can watch this show and past shows by going to pbssocal.org or rickreiff.com. You can also catch our shows in our post-show open mic chatter on YouTube and follow us on Facebook, Twitter, and Instagram. Thanks for watching. We'll see you again on Inside OC. Inside OC is brought to you by
Each new community 5 Point brings to life represents a promise delivered. Great neighborhoods are more than just places to live, they are places to connect. 5 Point is a proud sponsor of public television and community programming.
All your life, people talk about what's best for you. But to most people, it's just that. Talk. Unless you're with Memorial Care, a healthcare system devoted to one important thing: what's best for you.